Welcome to the award-winning AUA Leadership and Business Podcast, an official podcast of the American Urological Association.
Welcome to the AUA Leadership and Business Podcast, where urologic professionals experience the practical applications of business acumen essential for success in today's dynamic professional landscape. I am Steve Riggs, and I'm here today with Dr. Glenn Werneberg to discuss AI, intelligence, and urology, what's here and what's next. And I'm really excited about this opportunity. Glenn is a physician scientist and urologist in neurourology and pelvic reconstruction at the University of Michigan. His research bridges basic science, translational medicine, and emerging technologies, ranging from the urinary microbiome and neuromodulation to artificial intelligence and quantum-enabled artificial intelligence in urology. He serves in leadership roles across international societies, including the International Neurourology Society and the International Consortium and Consultation of Incontinence Research Society. He leads global sessions on AI and data science in the lower urinary tract. He's published over 60 manuscripts. He's received multiple awards, including the Diokno Lapidus Award, and he receives research funding from the NIH industry and urologic societies. In addition to his voluminous academic work, he consults with MedTech on device innovation, clinical trial design, and regulatory strategy. Glenn, it is a pleasure. Welcome.
Thanks, Steve. It's great to be here.
I know this is going to be a hot topic. We talked about this before. I think it's really going to resonate with our listeners. I want to start, if you can, and level set things about your background, how you got started in AI and urology, and kind of just level set your knowledge and expertise in this space.
So I'm a physician scientist in the field of urology. I'm trained also in biochemistry and biophysics. I did my PhD dissertation research and subsequent efforts, and they were related to protein-protein interactions in bacteria and how those underlie infection in urology. But during this process, I had the opportunity of attending a lecture at the campus of a prominent financial company nearby. The company and our institution's math departments had some close interactions. And the invited speaker, this was back in 2015, was Professor Jürgen Schmidhuber. He's a very well-known German computer scientist, and some have described him as the father of modern AI. He's known for his pioneering work on artificial neural networks and long short-term memory. And these are technologies that are widely used today and present on most of the smartphones in the world. But he spoke about potential AI applications across industry. Of course, he had a focus on the financial sector given his audience at the time, but I took away from this that some new motivation to understand how AI could help us in healthcare, and specifically urology. This marked the start of my AI-related work, and one of our first efforts at the time was to use AI to correctly predict treatment outcomes. So we looked at a condition called overactive bladder, which has a number of treatments. We wanted to predict whether or not a patient would respond to a given treatment. And this was our start.
So I think for our audience, if we could just kind of do another level setting and think about, for our audience in particular, what is AI? What is it not? Can you walk us through some of the evolution of AI as we get into this?
At its core, AI is simply just a set of tools that allows computers to recognize patterns and make predictions from data in ways that sometimes can exceed what humans can do. So in medicine, that could mean identifying patterns in imaging or lab results or patient-reported symptoms or a bladder diary, for example, that we wouldn't easily be able to notice ourselves. It's not magic, it's not a doctor in a box, and it doesn't replace clinical judgment or, importantly, empathy. But AI is also not omniscient. It can't think in the way that we do. It doesn't understand context, for example, or values or patient goals. It's also highly dependent on the data that it's trained on. So if the data are biased or incomplete or misapplied, the output will be just as flawed and in some case amplify the flaws. So the way I think of it is that AI is a powerful pattern recognition and decision support tool. It can augment what we do, but it's not a replacement for clinical expertise or patient relationships or the ethical framework we need in healthcare. So the opportunity really is this synergism between AI's strengths, which are scale and speed and pattern recognition, and our human strengths like judgment and compassion and ethical decision making. And I think that's really where the real progress lies.
And walk me through what your current focus is. I know you said this a little bit in the introduction, but where are you specifically using AI in terms of your team and research right now?
So, as I mentioned, we initially focused on this important problem in functional urology, predicting whether a patient would or would not respond to a given treatment. So from there, we now have a suite of AI-based tools that can make these predictions very accurately. As we developed them, we understood quickly that given overactive bladder is really a quality of life condition and treatments are elective, being able to predict a patient's perception of improvement is equally, if not more important than predicting someone's objective response to a treatment. So we've also incorporated an element of patient feedback and a focus on predicting how patients will perceive or not perceive symptomatic improvements following a given treatment. And since that time, we've broadened our efforts to more general and more challenging questions. For example, according to the World Health Organization, antibiotic resistance is one of the top threats to humanity today. One of the main drivers of antibiotic resistance is the misuse and overuse of antibiotics. And there's a lot of antibiotic prescription. Over 70 billion doses of antibiotics are consumed annually. It's about 10 pills per human on Earth. And as urologists, we see this firsthand because the urine culture, which is the gold standard diagnostic for urinary tract infection, it takes about 3 days to result. So while that result is being awaited, generally empiric antibiotic therapy is prescribed. And unfortunately, clinicians get that antibiotic choice wrong up to 30% of the time. And this requires modification 3 days later when that culture finally comes back. So I'll give you an example of this, and we see it every day. A 30-year-old female presents to urgent care with pain during urination and urinary frequency. She's prescribed an antibiotic and a urine specimen is collected and sent off for culture. But her symptoms persist. She calls the same facility a couple of days later and they tell her, continue the course of antibiotics. But the following day, the culture sensitivity finally results and she gets a call back and she's told that the antibiotic needs to be changed. So she picks it up the next day. For this patient, she ultimately winds up with 4 days of unnecessary symptom burden and 4 days of an ineffective antibiotic and all the collateral damage that comes with it. And finally, the associated cost and time burden for her, the providers, the facility, all during this 4-day time period. So we've developed a solution for this. We developed a suite of algorithms that predict a culture's susceptibility or resistance to antibiotics. We trained them on millions of cases, over 4 million cases, and then we externally validated them on a different hospital system in a different region in the United States. We validated our algorithms on about 1,100 cultures, and of these, 60 additional were accurate based on the model's predictions that were not accurate based on what was actually prescribed. So when we look at implementation of this suite of algorithms broadly, there's a lot of opportunity. About 25% of our 34 million hospitalizations in the US have an associated urine culture. We estimate that if we were to implement our algorithm broadly, it could result in almost 900,000 additional cases annually where an appropriate antibiotic would be chosen, translating to about 2.5 million days of unnecessary antibiotic doses in the US avoided every year. This would be a great step forward for the patient outcomes, fiscal responsibility, and antibiotic stewardship.
I love this example because I think what you've now said twice is this interaction of human with AI, not replacing, but creating synergy. And at least in this example, if I have it correct, shifting the knowledge up front to the provider, allowing them to be better at the point of care, right? Versus this delayed reactive, I don't know our local antibiotograms. I just usually do this. I always start them on this antibiotic and I'm always in this 3 to 4 day window of which X percentage, it's never going to be the right choice. It's just going to create resistance. And we actually didn't meet the need of the patient at the point of care because we always had this 2 to 4 day delay.
That's exactly right. So the idea is to shift it from day 3 to day 4 to giving the clinicians that information at day 0.
And I think you're seeing this in a lot of other areas. And I just want to explore this for a little bit more here. Can you roll me into some other areas? Because I think this context of like point of care or like bringing more information to the clinician in real time to let us be better at what we do is a concept that really resonates with me. So what else are you seeing in AI that's being used in urology?
We're seeing AI touch nearly every part of urology. I'll cover first AI scribe software. It's perhaps what we're most familiar with right now. And just briefly, essentially, this is AI listening passively to a patient encounter and generating a note for a physician's review and editing where appropriate. And clinicians right now spend a significant amount of time with documentation. Multiple studies have shown there's about 1 to 2 hours of documentation per 1 hour of patient care. And in urology, we have complex encounters. We're looking at multiple tests, outside records. So we're certainly not immune to this paperwork burden either. Now, AI scribes can reduce the burden substantially. We're starting to see formal analyses of AI scribe implementation. A number of studies have demonstrated reduction in perceived burnout, as well as measurable reduction in charting time and off-hours charting time as well. So that's an exciting opportunity. If we shift to radiology, radiological applications within urology, we're seeing some exciting AI applications too. So, for example, it's becoming increasingly clear that prostate MRI interpretation is more consistent and more accurate when there's AI support involved. A recent study showed improvement in radiologic diagnoses of clinically significant prostate cancers in cases where an AI assistance was used. And some of these technologies have also been cleared by the FDA already. On a systems-wide level, healthcare systems are increasingly using AI on the operational side. Platforms right now can analyze vast amounts of systems level data, things like referral patterns, quality metrics, claims data, resource utilization too. From these data, they can generate new insights and uncover inefficiencies and highlight best practices. Another example is that AI can detect which service lines or regions within a health system are consistently delivering the best outcomes at the lowest cost, and then generate actionable insights based on these that can then be scaled across an entire system. So whether that means redesigning a referral pathway or reallocating a resource or adopting proven care models more broadly, these are all potential applications here. We're seeing...
Go ahead. Sorry.
We're seeing AI used to retain referral networks as well within a network and to optimize staffing, even accelerate clinical trial recruitment by automatically scanning EMRs to find eligible patients. A common issue that we see in clinic in the operating room is template optimization, scheduling template optimization. In some cases, there are efforts to standardize the templates across departments. This approach, usually with the goal of streamlining access, can pose some logistical issues given unique nature of different subspecialties within medicine. And AI can identify patterns within a given medical or surgical practice and provide tailored insights to a particular clinician or a group of clinicians to optimize templates and scheduling. This is an approach that often winds up being more cost-effective than broad strokes template application across departments. So it's helping individual urologists. It's also giving hospital leaders and decision makers a strategic tool to improve both patient outcomes and the financial health of the institution. So at this point, it's no longer futuristic. It's woven into our practice. It's in the exam room, the operating room, and the conference room.
So very nice summary of what's available. What I think what you're articulating, correct me if I'm wrong, are things that you're already seeing being put into practice, right? You talked about radiology, you talked about operational efficiency, you talked about the ability of AI, I believe, if I have this correct, just to consume this large amounts of data and help distill it to digestible insights that you're interacting with as a human. What's on the horizon? Like what are you seeing? And you have a lot of knowledge, you're in this space. Like, what are you seeing are the next steps? What's exciting to you? Not just what's here, but what can be here?
Exactly. So what I just described are things that are already being implemented to various extents, but the future has a lot of promise and a lot of additional applications and a lot of additional inroads here. So one of the most exciting opportunities is the integration of multiple data types into a single model to guide diagnosis or treatment for an individual patient. So we can imagine a system that can simultaneously process all of a patient's imaging, laboratory values, clinical history, perhaps even genomics one day. Of course, all based on the consent of the patient, and then generate a personalized treatment recommendation. And this is the kind of holistic integration that has the potential to significantly improve outcomes across the board. We are reaching this critical juncture in medicine where the volume and complexity of available data is surpassing what a human clinician can realistically synthesize in real time. So AI can harness that complexity and turn these overwhelming amounts of information into actionable insights tailored to each patient. Another promising area under investigation, which our team is working on, is quantum-enabled AI. In our group, we're collaborating with IBM, our industry partner, to build on our classical AI algorithms to generate quantum-enabled algorithms and insights. So we're using our uniquely large data set of these antibiotic resistance cases to test new quantum computing methods and better understand how quantum computing can help us move the field forward. It has opportunities to improve the speed and the accuracy of algorithms and to rely on smaller and less complete training data sets. We're also seeing how AI has the potential to advance autonomous robotics. Urology has been a long-standing leader in robotic surgery, but today's systems are still fundamentally surgically controlled, as we know, surgeon-controlled with robotic assistance. But that paradigm is likely going to change soon. There's a number of breakthroughs in computer vision and machine learning, real-time analytics, and we're approaching a where surgical robots are beginning to carry out defined portions of procedures autonomously, at least for now, on the benchtop. So it's not science fiction, it's happening already in other industries. If we look at aviation, autopilot's been safely landing planes for decades under pilot supervision. In the automotive industry, autonomous driving systems are already navigating busy streets. And just this past Tuesday, I was in Phoenix and took a Waymo for the first time. And essentially, in this case, you get into the car and you push go, and there's no driver. It took me from the hotel to the airport. It was safe and it was less expensive than the alternative rideshare apps that were available that day. So these are complex and high stakes environments as well, where an autonomy has already become trusted and is becoming routine. And I believe that medicine will be next. The role of the surgeon will also have to evolve from performing every discrete technical step to supervising systems that can execute routine in highly standardized tasks with a high degree of oversight. But in the end, this can mean fewer errors and reduced variability and broader access to expert level care. It also raises some critical questions about training and responsibility. So it's a disruptive shift and one that we have to be starting to prepare for now.
Let me let me just follow up a little bit on that. Like, and you hit the buzzword at the end for me. I mean, clearly this would level set some of the variability, right? It would increase the opportunity to more standardize, to more understand. You say quantum. I don't always know what you mean when you say quantum. Can you help bring that forward to us in a little bit more simple understanding? Quantum computing. What's unique about that?
So at the fundamental level, the unit of computing for classical computing is the bit. It's either 0 or 1 or yes or no. In quantum computing, it could be 0 or 1 or yes or no, but anything in between can also be the case, or it could be any number of variations of everything between 0 and 1 all at once. So in theory, it has the opportunity to arrive at much more accurate predictions much more quickly. Theoretically, it's an opportunity to more accurately characterize the real world. So there's a lot of interest in research and development surrounding quantum computing, and to understand what types of data are best served with quantum computing. So for example, in our data set now, we're looking at particular cases wherein quantum computing is outperforming classical computing. And together with IBM, we're looking very carefully at what these data look like. What is it about the data that are more amenable to quantum computing than classical computing? And finally, how can we scale this to a point where we're seeing advantage of quantum computing relative to classical computing? So there's a lot of interest there and a lot of exciting work.
And so what makes robotics or quantification thereof, I would say like automation thereof, is there a parallel channel of what we're asking robots to do is less, right? Like we're asking robot for one procedure instead of like, hey, I'm supposed to be doing multiple procedures, or is this just going to happen agnostic to that?
Well, some of the first applications that we're seeing on the benchtop are operated with discrete steps and relatively low complexity. So, for example, one group has demonstrated that they can perform a cholecystectomy, a gallbladder removal, on the benchtop of the lab without human intervention. So this is a first step. In that particular case, I suspect they'll be looking to look next to animal models and cadaveric models, and hopefully, if their results are positive, one day they'll see their work making its way into a clinical trial, of course, with a very, very high degree of expert human oversight. But in the end, if we can train the models on expert, high volume surgical operations, we'll be able to broaden the access to high level care. And that's the hope for the future.
Very interesting. So I know you have some knowledge in the regulatory space, and you mentioned this a little bit before. Like, what do you worry about in terms of AI? I mean, it's coming at us fast, and it's constantly in the news and constantly in our face. And I think it gives a fair amount of folks some concern, or like, hey, not just how do I interact with this, but like, how do I know it's safe? Can you talk a little bit about the regulatory, what's going on in your world and maybe nationally around that landscape?
So when we consider deploying AI in healthcare, regulation and safety are, of course, front and center. AI tools AI tools for diagnosing and treating medical conditions are classified as software as a medical device, and these fall under the FDA's oversight in the United States. And there are similar frameworks in the EU as well under its AI Act. But what regulators look for are several aspects of AI-based technology, but there are three main categories. So these are transparency, validation of the algorithms, and model drift. Transparency is whether clinicians can understand how the AI reached a decision. And historically, AI had been considered a bit of a black box, and people frequently continue to bring this up because historically that had always been the case. But now we're seeing that many, if not most, models are designed to be explainable, because this transparency is so important for a clinician to get that information, to understand how the AI arrived at the decision. So that's transparency. Number two is validation, and this is whether and to what extent a model has been tested in diverse and external populations, not just the data it was trained on. In terms of the third category, or model drift, regulators consider whether a technology continues to perform well over time. So patient populations can change, practice patterns may change. All of this requires ongoing governance to monitor for model drift and mitigate that and correct it. So safety is critical. For example, a misclassified prostate lesion or inaccurately measured tumor can have real adverse consequences. So that's why this high-level validation and human oversight and governance are essential. And governance, by the way, refers to the process put in place by a system to oversee AI tools once they've already been deployed. So it's not enough to evaluate them once and approve them. They need to be continuously monitored, and there needs to be clear accountability and defined escalation pathways for if and when a model underperforms. So governance also includes establishing the entity that takes on the responsibilities, the responsibility of the vendor, the manufacturer, the hospital, the prescriber, or someone else. Healthcare systems are commonly creating AI officers or digital health officers as well as AI oversight committees. So these are much like pharmacy or therapeutics committees for drugs, but they review new tools to ensure their alignment with institutional priorities and standards and monitor the performance and practice. So they ensure governance covers bias, equity, explainability, and the role also includes making sure these technologies benefit all patient groups fairly. In the end, the governance is about trust. Clinicians need to trust the tool, patients need to trust the care, and the healthcare decision makers need to trust that the systems are safe, effective, cost-effective, and aligned with the institution's mission.
What do you say to the clinician or the urologist that's uncertain about this? Like, I guess I'm asking, like, what's the clinician, the practicing urologist in any environment? I mean, how do you see their role? What questions should they be asking? Like, what gives us confidence or should give us confidence that we're seeing the appropriate regulatory framework and confidence in what we're using?
So as urologists, we really should start engaging with AI tools now. This might take the form of trying out an AI scribe in the clinic or participating in pilot programs of predictive analytics within a healthcare system. And I think the comfort in using these tools, like anything else, comes with use. So an example in my case was signing up for our system's AI scribe. Many of us, myself included, were resistant. Over time, we have, of course, developed a workflow that works for us, whether it's using a particular note format or dot phrase or physical or virtual scribe, other methods. So in many of our cases, this transition to an AI scribe had a fair degree of activation energy, if you will. This first step is often the most difficult, but for those who I've spoken to, they've had a lot of success with the transition, and they haven't turned back. They've known expedited charting time, similar accuracy, and they've been very happy with the transition. The other point to address your question is that we have to sharpen our skills as critical evaluators. So we need to be able to ask, what was the technology trained on? Has it been validated? And if so, what population or populations has it been validated on? And how might it perform in my own patient population? What is it about my patient population that differs, if there are any differences, from the population it was trained on? And finally, it's about the rediscovery and leaning into our own unique human strengths. So machines can analyze and synthesize data and improve our workflow, but as I mentioned earlier, they can't provide empathy. And the best urologists and the best clinicians in the future are going to be those who can integrate the AI-driven insights while also deepening the humanness of clinical care. So for millennia, human value is tied to what we could do with our hands, like hunting, gathering, building. And then the Industrial Revolution shifted our value towards what we could do with our brains. And that worked well for many years. And now, as the AI era unfolds, I think there's going to be a new shift. And this time it's going to be to what we can do with our heart: compassion, empathy, connection. I think AI will give us an opportunity to reaffirm that humanness, which is our greatest asset.
Yeah, it's interesting you say that. And I've heard this before. You did a really nice job of articulating it. Like, on one hand, as clinicians or folks that have not adopted or not been on the forefront of adoption, we get worried about AI. But what you're really articulating is an opportunity to engage, to focus on the humanness of the interaction, right? To really embrace the attributes and the reasons why a lot of us go into medicine, the physician-patient interaction, the empathy. Did I understand that correct? I mean, is that where you see the real power in this, the real opportunity for us as clinicians?
That's exactly right. I think even if we just think of it in a very simple way, when we're removing the typing and the dictation from the clinical burden during our physician-patient interaction, it really opens up a lot more in terms of the ability to truly listen and understand what the patient is telling us, and to be able to provide that empathy, without that tethering of the typing and the dictation, and really just be able to listen. And I think that with the additional time that AI will help us to free, we'll be able to provide more and more of that.
So you talked about clinicians using it, whether it's just for scribing, right, or just interacting daily, or evaluating data sets, right? I think what if I hear you correctly, your recommendation is just start engaging with the technology and being curious and asking questions. And certainly if you're in a hospital system or practice, ask the questions of those that are trying to engage around the regulatory for that particular aspect, hospital or practice. Yes?
Yes. So engage, certainly, but continue to be skeptical, but be willing to try these things and see if they work for you, because AI is not going to stop advancing. It's not going to stop having additional applications. And if we start engaging with the technologies now, it makes it easier and better to keep up with them as they continue to evolve. Even if they won't drastically change our practice now, chances are those things that will drastically change our practice will be available in the upcoming months and years. So I think it makes sense to start here, start early, and be open-minded regarding what AI can do for us in our practice.
One final question. Do you have any resources, and maybe we could put a link in the show, just if people are like, hey, I don't know where to start, whether it's a book, whether it's something to give them confidence and, simplify. I do think there's a lot of barrier. You talk about segmentation across our workforce, right? We got a lot of older workforce. I'm assuming this is probably easier for people that are younger. Any offhand recommendations about where somebody would want to start before they even use it, to be like, hey, let me better understand this? And if not, maybe you can think about that and we can put something in the meeting notes.
Yeah, absolutely. I'd be more than happy to get some of those together for the meeting notes. There are certainly some great opportunities available, including from the NIH, and these vary from regulatory issues also to implementation issues for people to consider who are thinking about using AI for the first time.
Glenn, you've been awesome. This is, I've really enjoyed this. Thank you. You have a wealth of expertise. So I really appreciate you being on with us and for sharing your time. And thank you to our audience for joining us on the AUA Leadership and Business Podcast. Until next time, continue to learn, lead, excel, and stay curious.
Make AUA Leadership in Business your go-to podcast. Subscribe today by searching Leadership in Business on your favorite podcast app and enhance your leadership and business education needs. Until next time, continue to learn, lead, and excel.